Hello everyone, Floyd here with Curbside to Bedside. Today we're going to talk about COVID-19 and I want to provide some guidance for EMS providers with a caveat that I am not an expert by no means. However, I'm going to talk about things that you can do to protect yourself, your coworkers, and your family members. This is not to supplant your current local policies or protocols or to replace them. However, if you are working somewhere that has not provided much direction, then by all means do what you must to protect yourself. For the purposes of this podcast, I'm going to be calling it COVID-19. However, the virus is called, SARS-CoV-2, severe acute respiratory syndrome coronavirus 2, which is the causative agent of the 2019 coronavirus disease, i.e. COVID-19. But for the purpose of this talk, we're going to call it COVID-19. So, how is it spread? Well, we know that it is clearly spread via droplets. So if someone coughs or sneezes and you're in direct contact with them, then you can get the virus. It is possibly and most. So when we get into the symptoms, we're talking about screening patients. Now, how should they be screened? Well, they should be screened by, first, your PSAP, your public safety answering point. They should be implementing protocols for screening them, by asking certain questions to determine what risk they are so that they can then notify first responders so that they can don the proper PPE before they even enter the residence. However, not every patient is going to be caught by your PSAP screening, no matter how good they are. And I have a lot of respect for those at our local PSAP. But no matter how good your system is, not every patient is going to be caught. So let's imagine that the door to the patient's house is impenetrable until they are properly screened. The screening can be conducted from across the room. So how do we screen patients? Well, we want to know, do you have a fever? And this could be asking the patient, do you have a fever? Can you touch your forehead? Do you feel like you have a fever? Even though we're the healthcare professionals, patients generally know when they have a fever. They have a pretty good grasp on that. And then other symptoms that you want to watch for or ask for when screening or surveilling these patients are cough or sore throat, shortness of breath, and do they have a recent international travel or recent contact with a person suspected or known to have COVID-19, and the time frame is generally within the past 14 days. This can get a little nuanced. Not every patient presents with fever, cough, shortness of breath, or sore throat. They may just present with malaise. However, the incidence of the symptoms presented in is generally insufficient, especially if you're going to be doing certain procedures where things could splash on your face. I know a lot of EMS departments are actually using face shields. So let's back up. PPE is eye protection, face shield, gloves, gown, and a respirator. Now, this could be N95, P100, PAPRs. Each service will have to determine which respirator they want to use and which respirator they want to fit test on their folks. Now, your service should be conducting fit test. If not now, they should do it soon. A lot of services are having trouble finding respirators. Now, the N95 is not the only respirator that you have to use. There are P100s. There are multiple different respirators sufficient for calling them respirators that you can use. Now, the CDC has released interim guidance for the use of surgical masks instead of respirators if you have a critical shortage. But there are certain caveats to that because surgical masks are not effective if you're performing aerosolized or aerosol generating procedures. So even though you can wear a surgical mask under your face shield, if you're going to be nebulizing medications or performing airway procedures, then that is not going to be sufficient. So even if you might have sufficient respirators, maybe you should consider using a surgical mask instead of a respirator if it's possible that your supply might become overwhelmed and might get used up. The CDC has released reuse guidelines. Currently, we are taking our N95s and assigning an N95 to each provider and placing them in a brown paper bag per CDC guidance. So other than PPE, what are certain things that you can do routinely to minimize the risk of exposure to you or your team? Well, clearly, you want to do those things that they talk about in the news that you see on social media every day, which means wash your hands. Don't sneeze into your hand, sneeze into your elbow or into a tissue, and stop shaking hands with people. So maybe we should elbow bump. I really like doing elbow bumps. Now, it's really hard to get into the practice of not shaking hands with people. So maybe you could just start, elbow bumping with your family or your friends to try to get into the habit, make it something that's fun. And it is kind of fun and funny when people when people hold out their hand and you hold up your elbow. So it's like elbow bump, bro. So in addition to those things that everyone should be doing, we want to perform routine cleaning and disinfection on all ambulance surfaces. And you want to pay particular attention to items that have come in contact with the patient or possibly have come in contact with the patient. This means all surfaces. So you know how well we currently disinfect and clean our ambulances? Well, we want to actually start doing what we say we're doing and then ramp that up a little bit more. When you conduct a daily inventory, check your supply of your PPE. Depending on your ambulance configuration, you might want to keep some supply in the front of your ambulance, and we'll get into why later. Go ahead and turn the exhaust fan on in your ambulance in the patient compartment. This can draw air away from the cab of the ambulance. Go ahead and separate your patient and driver compartment. So if you have a door or a window that separates, that can separate those compartments, go ahead and close them. And I'm sorry to say that if you don't have something that can separate those compartments, then the driver is going to have to wear full PPE as well. Even if you have separate driver and patient compartments, you need separate ventilation systems, or you need a ventilation system that can pass through a HEPA filter. Now, I'm not an expert on ambulance design, so I don't know much about this, but it's something that you might want to ask your administration. So if you work for a service or if your system routinely has additional first responders routinely responding to the scene for patients with difficulty breathing, shortness of air, then you might need to implement system-wide controls to reduce the number of people on scene, because we want to remove unnecessary personnel by controlling the point of entry. So if your fire department typically responds, if it's a patient having difficulty breathing, maybe they should not respond to those calls. And that's something that each service will have to determine for themselves what they're going to do. But if you get on the scene of a patient having difficulty breathing and you walk in, and it's not your run-of-the-mill acute severe asthma exacerbation in a patient with no exposure, no travel history, and no other symptoms, then maybe you should cancel the incoming units unless you really need their help. So start canceling people, reduce the number of people on scene. You may even want to limit third riders. So if the family won't ask to ride in the front of the ambulance, maybe it's time that you say no. But you do need a plan to limit other first responders. Even if you don't have a plan, you still can control the point of entry on your scene. A lot of schools are actually canceling their field internship programs during the interim until this thing gets a little more under control. All right. When you're managing the airway of a patient with suspected COVID-19, how aggressive should we be? Well, first of all, I think that you should probably consider placing a blind insertion airway device, i.e. a King Airway or iGel. iGel is my preference. Rather than performing endotracheal intubation. This actually limits how close you have to be to the patient's face and reduces the risk of something splashing up onto your face and getting into your mucous membranes. However, if you must perform endotracheal intubation, then it is preferred to use VL. You want to optimize first pass success. So if you're working on an airway and you generally have like 4 people down there helping you, you probably want to limit it to 2 people. Now, Scott Weingart recently released a podcast going into detail on this, and it's much better than anything that I could say. So I will link to that, and I recommend you go and listen to it. But if you want to optimize your first pass success, your chance of getting securing the airway on the first attempt, then honestly, you probably need more than one airway operator. But whoever is down there should be in full PPE, including wearing a respirator, not just a surgical mask. But in EMS, there's little reason that you shouldn't be able to use a blind insertion device, and let the hospital perform endotracheal intubation when they have more resources and negative pressure rooms and possibly even better PPE. Now, if paralysis is available, you probably want to maximize your dose to really ensure that the patient is not breathing. And when managing a patient's airway, no matter if you're using, if you're ventilating through an ET tube or a blind insertion device, if you're ventilating with a BVM or a mechanical ventilator, use a viral filter. Now, if you're placing the patient on a ventilator, you need to consult your device manufacturer on that to determine what filtering system you need or what configuration you need to adequately protect cross-contamination between patients, and also to ensure that the exhalation is not dumping out into the patient compartment of the ambulance or the room without passing through a viral filter. We use Hamilton T1s, and they actually recommend viral filter on the inspiratory and expiratory outlets. And they also recommend a viral filter on the patient side of the ventilator circuit after the flow sensor to protect not just the flow sensor, but from the possible retrograde flow from, flushing from the ventilator out through the flow sensor and to the patient. Now, if you do use a mechanical ventilator, what generally happens after you get to the hospital and you take the patient off the ventilator? We don't usually put the ventilator on standby before we transition from our ventilator to the hospitals. And this causes a problem because what happens if you don't put the ventilator on standby and you just disconnect the ET tube? Well, the ventilator starts surging air and pushing it out the circuit, and it just goes crazy. So then all of that, and then it can just, blow the virus around the room. So you want to place the ventilator in standby mode immediately before disconnecting your ventilator. So you need to know how to do this on your particular device. Now the patient is going to be without oxygen for a few seconds, but this is something that you can practice and get really good at so that there's an insignificant amount of time that lags between putting the patient on standby, disconnecting the ventilator, and putting them on another ventilation system. You can also consider clamping the endotracheal tube, especially if the patient's breathing spontaneously, so that they don't just blow all of that air out the ET tube and into the room. When you're managing a patient that's having trouble breathing, we usually have a low threshold for giving nebs to everyone. I mean, every single patient that has trouble breathing, you get a neb, you get a neb, and you get a neb, regardless of if they honestly need it or not. So I'm here to tell you that we need to stop that practice in general. We need to stop the practice of routinely giving nebs and and conduct a proper assessment to determine what the patient actually needs. But for this, epidemic, if I can now call it that, we want to avoid aerosol generating procedures if at all possible. This means if the patient really, really, really does not need a neb, or not even 3 reallys, just 1 really, but even if you think that they might need a neb, but they're not in such severe distress that they're verging on respiratory failure, then let's still avoid nebulized medications. If you really think that they need a neb, then it is probably best to deliver that neb through BiPAP or inline through BiPAP or CPAP, only if you have a closed system that does not dump the exhalation directly into the room. So our masks that we use at our department don't have a flapper on them to direct exhalation into the room, and it's a closed system. So as long as we have a good seal, then all of the exhalation is going to be exhaled through the viral filtering system, mostly just like it would if they were intubated. Now, you need to look at your equipment and determine if that's the case for you. And if that's not the case for you, then maybe you need to look into a system that might work for this. When ventilating patients with a BVM, you want to place a viral filter between the BVM and the mask, or between the BVM and the endotracheal tube or biad if they're not being placed on the ventilator. You can buy viral filters relatively cheap. They might be in short supply right now, but we were able to get them. I prefer to place an end-tidal CO2 on our BVM as well, so that we actually know we're ventilating the patient. So our system goes BVM, end-tidal CO2, and then filter before it reaches the patient. And when you're ventilating patients with a BVM, you want to ensure a perfect mask seal. I don't mean just nonchalantly throwing the mask on the patient and the person that's actually, performing, that's maintaining the seal is engaged with everything else that's going on the scene, and they're not really paying attention to whether or not they have an adequate seal. No, that person that is maintaining the seal is in charge of protecting everyone else in the room, and that is the most important job. That is their only job at the time. Now, that's how it should always be. And maybe this current situation will actually help improve our airway management if we properly train on it. So, to maintain a perfect mask seal, that means you use 2 people. One person maintains the seal with 2 hands, 2 thumbs on the mask. The rest of the fingers go around the jaw and pull the jaw into the mask. And those hands that are on the sides of the mask are feeling for any air that is leaking out. Now, if you don't have to perform BVM ventilation, if the patient is awake and alert, maybe you want to consider using a non-rebreather, something that is mask-like. But again, if you're running a non-rebreather at 15, 20, 25 liters per minute, which it can do, and I hope you know this, that could also be just blowing a lot of aerosol around the room. So we just need to be really, really cognizant of this, and maybe even practice doing these procedures wearing full PPE. After the call, How do you clean and disinfect? Well, you want to wear disposable gown and gloves, and plus or minus a surgical mask or respirator if you think that splashes and sprays are anticipated. I also want to emphasize that you want to ensure a proper wet time based on whatever disinfectant you are using. The CDC has linked to something from the EPA that has a list of disinfectants that you can use against COVID-19. So I will link to that in the show notes. But most hospital grade disinfectant will work. Now, what constitutes an exposure? So what do you do if you transport a patient that has COVID-19? Do you have to go in quarantine? A lot of people might think that, but that is not always the case, and it depends on what your risk category is, and the CDC actually breaks this down quite elegantly, and that is something for your administration to decide. They will have to investigate. So right now, if you think that you possibly have an exposure, what you want to do is isolate yourself from other people, immediately notify your supervisor, and then hopefully they have a plan on how to investigate a potential exposure and how they're going to proceed from there. Additionally, some departments are conducting routine self-monitoring throughout the day, and especially first thing in the morning, they're conducting temperature checks. And again, you need to talk to your administration to determine what their plan is. So as always, I hope that you enjoyed this, and I'm sorry that it took me so long to get another podcast out, but as you can imagine, there has been a lot going on. If you ever have any questions, please let me know, and I hope that you will share this with your friends. Thank you.